Thank you, Daniel. Today my talk is entitled Testosterone Decline in Aging. And we're going to talk about the location of androgen receptors and the function of testosterone at those androgen receptors. I will also be discussing the importance of aromatase in aging, as well as describing the symptoms and diseases associating with aging that improve on testosterone therapy. And finally, if there's time, I hope to cover controversies surrounding testosterone therapy. Now, not everyone's going to have the same opinion, but difference of opinion leads to inquiry, and inquiry to truth, and that, I am sure, is the ultimate and sincere object of us both. Many physicians disagree with the Endocrine Society's clinical practice guidelines. They recommend against making a diagnosis of androgen deficiency syndrome in healthy women, and data correlating androgen levels with specific signs and symptoms are unavailable. Androgens, receptors, and function. Testosterone is the most active hormone in both sexes. It is produced in the ovaries, testicles, and the adrenal gland. And more importantly, it is produced at the cellular level from androgen precursors. Testosterone has a direct effect at the androgen receptor. It's also a precursor for dihydrotestosterone and estradiol, which has an effect at the estrogen receptor. Interestingly, the androgen receptor is located on the X chromosome. Take a second and look at this slide. What's wrong with this slide? I saw a similar slide presented at an international meeting, and the speaker stated that testosterone levels fluctuate during the menstrual cycle. This is true, but she went on to say that estrogen is found in much greater quantities than the testosterone in premenopausal females. That is not true. Testosterone is found in greater quantities than estradiol throughout the entire female lifespan. Testosterone is also produced at the cellular level from androgen precursors. And look at the amount of androstenedione produced. It's almost tenfold greater than testosterone. Androstenedione is the direct precursor to testosterone. DHEA and DHEAS are also found at thousands higher rates than testosterone. Okay, do men or women produce more DHEA and androstenedione? Men and women produce approximately equal amounts of the androgen precursors. Testosterone is involved in lean muscle mass. It's also involved in sex drive and performance in both sexes. But now we're going to talk about the critical role of testosterone in other organ systems in the body. And much of this data was presented at the European Menopause and Andropause Society meeting in Amsterdam in May of 2017 as part of the Junior Mentorship Program by Dr. Adrian Valeroux. There are androgen receptors located in every organ system in both sexes. Testosterone also has a function at those androgen receptors in every organ system in both sexes. There are androgen receptors in the hair, skin, and scalp. Testosterone is responsible for secondary sexual characteristics in both sexes. It is also a precursor for dihydrotestosterone. There are large amounts of 5-alpha reductase found in the hair, skin, and scalp. Dihydrotestosterone is responsible for hirsutism, sebum production, acne, and male pattern hair loss. Testosterone accelerates wound healing. It thickens skin, decreases fine lines, and wrinkles. There are also androgen receptors in the eyes, ears, and nose. Testosterone improves dry eyes, dry mouth, and is beneficial in Sjogren's syndrome. Androgen receptors are also located throughout the brain and nervous system. And one of the most important functions of testosterone is that it is neuroprotective. It's involved in spatial cognition and focus, verbal learning and memory. It reduces depression and apathy, and is a mood stabilizer. It is anti-anxiolytic and involved with self-confidence. Testosterone also and help sleep patterns. We showed that 90% of women who complained of sleep issues improved on testosterone implant therapy. Here's a sleep pattern from a patient of mine. On the left-hand side, you see her sleep pattern at the end of testosterone therapy just prior to reimplantation. The blue lines represent restless sleep. On the right-hand side, you see her sleep pattern approximately 8 weeks into testosterone therapy. Testosterone also regulates beta amyloid. It is an immunomodulator and reduces inflammation. Testosterone has a beneficial or therapeutic role in Parkinson's disease. In fact, the first person I treated with testosterone therapy was an elderly man with Parkinson's disease that was so severe he could no longer hold silverware in his right hand or sign his name. There was a marked improvement in his symptoms with testosterone therapy. Testosterone also improves symptoms of Alzheimer's disease and dementia. On the left-hand side, you see a positive brain amyloid scan with significant cortical uptake. This gentleman requires significantly higher doses of testosterone, and we maintain levels above 1,000. If he goes past his 12 weeks, he develops multiple symptoms. He currently leads a normal life. Testosterone is also beneficial in multiple sclerosis. We also have to treat multiple sclerosis patients with higher doses of testosterone therapy. None of our patients have progressed on therapy. Testosterone also has a beneficial role in peripheral neuropathy, chronic pain, fibromyalgia. We have also shown greater than 90% improvement in migraine headaches using subcutaneous testosterone therapy. There are androgen receptors in the heart and blood vessels. Testosterone is a vasodilator. It augments cardiac output. It strengthens cardiac muscle, inhibits plaque development, and modulates cardiac adaptive hypertrophy. It has an angiogenic effect. Testosterone also reduces arterial stiffness. It improves oxygen consumption. It increases functional exercise capacity and has a therapeutic benefit in congestive heart failure in both men and women. Testosterone inhibits platelet aggregation and we have shown a reduced incidence of thrombosis in men treated with testosterone therapy. This is nothing new. Dr. Jens Moeller wrote a brilliant book in 1984 called The Testosterone Treatment of Cardiovascular Disease. There are androgen receptors in the lungs, trachea, and bronchi in both the mesenchymal and epithelial cells. Testosterone is a bronchodilator. It improves asthma. It's also a pulmonary vasodilator. Testosterone is anti-inflammatory and depresses sensitivity to histamine substances. There are androgen receptors found in the GI tract, liver, pancreas, and kidneys. Testosterone improves glycemic control. It increases glucose tolerance, enhances glucose-stimulated insulin secretion, and increases insulin sensitivity. Testosterone also stimulates peristalsis. It is anti-inflammatory in the GI tract. It's involved in the homeostasis of lipids. It stimulates erythropoietin and induces alcohol dehydrogenase. Testosterone suppresses the development of fatty liver, virus-related hepatitis, and cirrhosis. There are androgen receptors in the uterus, vagina, and bladder. It strengthens the bladder, improves incontinence and urgency, and has a positive effect on vaginal blood flow. Testosterone improves vaginal strength and lubrication and prevents the proliferation of the uterine lining. Testosterone therapy has been used to treat endometriosis, dysfunctional uterine bleeding, and uterine fibroids, and is currently being used in combination with aromatase inhibitors. Testosterone also treats lichen sclerosis. Testosterone is a precursor for estradiol in the ovary. It maintains follicular development and maintenance. It increases fertility. Testosterone also stimulates ovulation. It increases sex drive and libido and is involved in erectile function. Testosterone is involved with spermatogenesis, sexual maturation, and the development of the seminal vesicles. It's also a tumor suppressor and proliferator in the prostate gland. Testosterone is also involved in the stress response. Testosterone inhibits the hypothalamus-pituitary adrenal axis reactivity to stress. In other words, it decreases the stress response. It also decreases stress-related neuropathology and neuro-related psychiatric disorders, including PTSD and depression. This is in opposition to estradiol, which increases the stress response. Androgen receptors are located in the muscles, joints, and synovium. Testosterone increases lean muscle mass and strength, relieves pain, regulates dendritic morphology and growth in hormone-sensitive motor neuron populations. It's anti-inflammatory and is effective therapy for rheumatoid arthritis and autoimmune diseases. It is also used as a therapy for sarcopenia. There are androgen receptors in the bone and bone marrow. Testosterone enhances immune function, and this is used to treat patients with AIDS and patients on chemotherapy. Testosterone also reduces inflammation. Testosterone reduces systemic inflammatory cytokines and increases anti-inflammatory cytokine. Testosterone also stimulates the production of red blood cells. It increases nitric oxide and inhibits platelet aggregation. Testosterone reduces bone turnover, increasing bone density. It is also the precursor for estradiol in the bone and bone marrow, which also increases bone density. Androgen receptors are found in adipose tissue, and testosterone has been shown to decrease visceral fat and reduce waist circumference. Testosterone also aromatizes to estradiol in the adipose tissue. Obesity increases aromatization. There are androgen receptors in the breast and mammary gland. Testosterone inhibits proliferation and hyperplasia of the breast. It decreases estrogen receptor alpha and increases estrogen receptor beta. Testosterone is pro-apoptotic and inhibits breast cancer cell growth. Testosterone also increases chemotherapy responsiveness in breast cancer patients. It can aromatize to estradiol locally and stimulate tumor growth via estrogen receptors, so one has to be careful. Testosterone, we have shown that testosterone can reduce the incidence of breast cancer in women treated with therapy. We've also shown a reduced incidence of recurrence in breast cancer survivors treated with testosterone or testosterone combined with an aromatase inhibitor. This is a mammogram of an 82-year-old patient treated by my partner in Greece, and she initially presented with a large 4.5 centimeter palpable right breast mass and palpable axillary adenopathy. On the right-hand side, you'll see a picture of a follow-up mammogram, 9 weeks following treatment with testosterone in combination with anastrozole. On the right-hand side is her mammogram at 19 weeks. She had almost complete resolution of her tumor. However, testosterone is not just for the therapy of disease. Testosterone has also been shown to improve the quality of life in breast cancer survivors. This is a 60-year-old patient who presented to my practice with very symptomatic. She complained of sleep difficulty, depression, irritability, anxiety. She was physically exhausted and needed her husband to help her walk into the room. She complained of memory impairment, no sex drive, vaginal dryness, and severe pain, probably contributed to by her metastatic bone disease. This is our symptom survey 2.5 years later on testosterone letrozole implant therapy. She was also able to get off multiple medications. So testosterone is not just about disease control. It can greatly affect the quality of life in breast cancer survivors. We're now going to talk about aromatase, location, function, and aging. Aromatase is located in every organ system in both sexes. Anywhere there's androgen receptors and estrogen receptors, the enzyme aromatase exists. Testosterone is a major precursor for estradiol in the ovaries and adrenal gland and adipose tissue. This amount of estrogen is measurable in serum. Testosterone is also the major precursor for estradiol in every cell and every organ system, and this amount of estrogen is immeasurable in serum. The peripheral conversion of testosterone is the major source of estrogen in men and postmenopausal women. Again, this amount of estrogen may not be reflected in serum levels. Increased aromatase activity and production happen in obesity. Certain medications increase aromatase activity. Disease states such as benign prostatic hypertrophy, endometriosis, and uterine fibroids increase aromatase activity. Certain cancers, prostate cancer, breast cancer, and endometrial cancer all produce aromatase, increasing local estrogen formation, which can be detrimental in these cancers. The ratio of estradiol to testosterone increases with age. Excess estrogen in the aging male can cause multiple symptoms: development of breast tissue, gynecomastia, fluid retention, weight gain, anxiety, emotional disturbances, erectile dysfunction, and lack of effect from endogenous testosterone or testosterone replacement therapy. High estrogen, and in particular in combination with low testosterone, is not healthy. It can increase the risk of stroke, progression of carotid artery intima thickening. It is associated with coronary arteriosclerosis and myocardial infarction. It is associated with lower extremity peripheral artery disease. It increases chronic inflammation, which is involved in many diseases. It increases insulin resistance, has an adverse effect on benign prostatic hypertrophy and prostate cancer. We're going to now talk about androgen decline, the clinical effects, and aging. Androgens decline with age in both sexes and almost all mammals. Have you ever wondered how castrate animals live healthy, normal lifespans? It has to do with the adrenal production of androgens. Testosterone peaks in men and women in their 20s and gradually declines thereafter. The adrenal prohormones, androstenedione, the immediate precursor to testosterone, also declines with age in both sexes. DHEA and DHEAS also decline with age. Individual symptoms may vary. Time of onset of androgen deficiency symptoms vary. Testosterone levels at the onset of symptoms also vary. And I agree with this statement. Though laboratory assays can support a diagnosis of androgen deficiency in men and women, they should not be used to exclude it. It is suggested that there needs to be a greater reliance on history and clinical features together with careful evaluation of symptoms and where and when necessary a therapeutic trial of androgens treatment given. Symptoms of androgen deficiency and aging in both men and women include physical fatigue, exhaustion, bone loss, muscle wasting, fat accumulation, thin, dry skin, wrinkles, brittle hair, and nails, chronic pain, muscle aches, and stiffness. And these really all make sense when you consider the location and the function of androgen receptors. Androgen deficiency also increases inflammation. Symptoms of androgen deficiency also include urinary incontinence, frequency and urgency, benign prostatic hypertrophy, vaginal atrophy, decreased sex drive and libido, and impotence. Dysphoric mood, depression, anxiety, irritability, loss of confidence, sleep disturbance, insomnia, vasomotor instability, hot flashes, cognitive changes, decreased mental focus, and memory loss. Age-associated diseases in which testosterone has been shown to be beneficial include obesity, coronary artery disease, congestive heart failure, pulmonary fibrosis, asthma, COPD, insulin resistance, diabetes, and metabolic syndrome. Testosterone is not only beneficial in certain cancers, but is beneficial in all cancers by its effect on stimulating immune function. It's also beneficial in neurological diseases, as we have shown, dementia, osteoporosis, and sarcopenia. Now I'd like to cover some of the controversies surrounding testosterone therapy. And remember, differences of opinion are welcome. And I'm sure not everyone's going to agree with what I say, and that's okay. I'm not entirely sure that hormone therapy in women should equal estrogen therapy. We published a study showing the impact of testosterone implants alone on 300 women, 1/3 of whom were premenopausal. No estrogen was given. And if you look at this, you see statistically a significant improvement in every symptom category on the MRS survey. True or false? Testosterone is contraindicated in breast cancer. We presented data at the American Society of Clinical Oncology Breast Cancer Symposium in 2014. And what we did was we looked at the efficacy of subcutaneous testosterone on menopausal symptoms in breast cancer survivors. This is a prospective study and included breast cancer patients stage 0 through 4. The majority of patients were estrogen receptor positive and were treated with testosterone in combination with anastrozole, an aromatase inhibitor. And we monitored estradiol levels. Again, we saw statistically significant improvement in all symptom categories: hot flashes, heart discomfort, sleep issues, depression, irritability, anxiety, physical or mental exhaustion, sexual problems, bladder problems, vaginal dryness, and pain. Testosterone with an aromatase inhibitor in breast cancer survivors improves quality of life. It also confirms the effect of testosterone on symptoms. It decreases breast cancer recurrence, and that's what we're seeing in these patients that we're following long term. However, testosterone alone is contraindicated in estrogen receptor positive patients. It must be combined with an aromatase inhibitor, and estrogen levels should be monitored. A low glycemic, whole food diet is critical to breast cancer recurrence, and we counsel all our patients on this. Another controversy is testosterone levels on therapy, and many guidelines recommend maintaining mid-normal ranges for both men and women on therapy. However, there's a problem with micromanaging testosterone levels: reliability, inter-individual variation, and intra-individual variation. The bottom line is, therapy should be based on clinical effect and therapeutic response versus side effects. We know that inadequate doses are ineffective therapy. This slide talks about inter-individual variation. And basically what we did was we looked at serum testosterone levels at week 4 after a 100 milligram implant in 12 women. The range on therapy ranged between 83 and 368, and a coefficient of variation of over 40%. It also depends on the method of testing. These are the exact same women at week 4 measuring salivary hormone levels. Saliva levels measure end organ response, or are reflective of an end organ response. And all but one patient was within the normal limits for salivary hormone levels. Again, we saw a coefficient of variation of over 40%. There is also intra-individual variation. This is a single patient who received 112 milligram testosterone implant, and we followed her for 26 hours. And there was over a 200-point difference between the low and the high, and a coefficient of variation of 25%. Hormone levels fluctuate and are unreliable. An individual patient should be treated based on his or her symptoms, response to therapy, as well as the benefits and risk of therapy. An individual's physical comfort may not be related to their absolute hormone levels. Remember, all adrenal androgens decline with age. And this is particularly important in females when we're talking about testosterone replacement therapy. You not only have to replace endogenous serum levels of testosterone, but you have to replace the significant contribution of the adrenal prohormones, which also decline with age. You have to get enough testosterone to the androgen receptor to create a physiologic effect. In our study, we showed at week 4 an average testosterone level of 300. This is 4 to 6 times endogenous ranges in females. And even more interesting, symptoms return when testosterone levels reached about 170 to 180, 2 to 3 times above endogenous ranges. We have seen no adverse drug events in any female on testosterone therapy. You cannot compare apples to oranges. You can't compare levels on therapy to circadian variation of endogenous production. In conclusion, testosterone decline in aging. The beneficial effects of testosterone, there are beneficial effects of testosterone on physical and mental health, disease prevention, immune function, glycemic control, and reducing inflammation, which is important in every organ system in the body. Androgen receptors are located in every organ system in both sexes. Testosterone produces a direct physiologic effect at the androgen receptor in all major organ systems. Testosterone also produces an indirect effect via aromatization at the estrogen receptor in all major organ systems. The role of excess estrogen, increased aromatization activity in disease states, should be investigated further. The causative role of excess estrogen in the side effects of testosterone replacement therapy should be addressed. Aromatase inhibitor therapy should be considered when indicated. Women at an increased risk for breast cancer, patients on testosterone therapy with clotting disorders, obesity, fluid retention, benign prostatic hypertrophy, erectile dysfunction, and other symptoms of estrogen excess. Testosterone is critical for human development and maintaining homeostasis. The gradual decline of testosterone associated with aging is responsible for many of the adverse signs and symptoms of aging, including mental and physical deterioration. Testosterone replacement therapy must be done with adequate doses. It's about the benefits versus the risk of therapy. I think we should agree to disagree with this recommendation that recommends against the general use of testosterone for the following indications: infertility, sexual dysfunction other than hypoactive sexual desire disorder, cognitive, cardiovascular, metabolic, or bone health, or general well-being. Guideline recommendations should be kept in perspective. They can cause harm. They can be biased. They can be wrong. They can be based on insufficient or low evidence. And it can result in withholding therapy or inadequate therapy. And in the United States, these guidelines, which may be wrong or controversial, are often used by state boards and cited in lawsuits. So I think everyone can agree with the following. Guidelines should not be considered inclusive of other approaches or methods or exclusive of others. Guidelines cannot guarantee any specific outcome, nor do they establish a standard of care. And that line is very important. The guidelines are not intended to dictate the treatment of a particular patient. Treatment decisions must be made based on the independent judgment of healthcare providers and each patient's individual circumstances. And I hope you will all join the 12th European Conference on Menopause and Andropause held in May 2019 in Berlin, Germany.
Okay, so thank you very much, Rebecca. That was very interesting, actually. So, sorry?
I'm glad you could hear it. I wasn't sure the whole time I was talking.
Yeah, I had a very small technical problem, but I don't know whether it was coming, but it was solved, and you could continue with the presentation, which is the important. So now we have a few polls that would need to be answered. So I will launch now the first one, and I will be giving you a few seconds to answer it. Okay, so let's go for the first one. So the most abundant biologically active hormone in women during their reproductive years is, and you have to choose between estradiol, estrone, or testosterone. Not sure about the correct pronunciation, but yeah, we are already, there are people already answering. That's nice. Let's give a few seconds more. Okay, let's um, mm, uh, no, I'm not sure that. I'm not sure we are. You are seeing the results. Sorry about this. Rebecca, are you seeing the results? I guess
No,
no.
I'm not seeing the results. There they are.
Oh, there they are. Okay. So what do you think about the answers?
Well, 83% of the people got it right, so I guess that's good. But testosterone is found in about 8 to 10-fold greater quantities, serum levels, than estradiol throughout the entire lifespan, even during reproductive years in females.
Okay. So let's check for the second one. Okay, here you have it. Insufficient levels of testosterone contribute to which disease associated with aging? Sarcopenia, neurological disease, MS, dementia and Parkinson's, heart disease, CHF and vascular occlusive disease, erectile or sexual dysfunction, or all of them, or all of the above. As previously, I'm going to give a few seconds. Okay, so let's check the answers. So 100%.
Excellent.
Not much to say. Everybody is clear about this. Okay, so let's go for the last one. Okay, which of the following age-associated diseases are improved with pharmacologic doses of T? Sarcopenia, neurological disease, and Parkinson's, heart disease, CHF and vascular occlusive disease, erectile sexual dysfunction, or all of the above? Okay, just a few seconds more. Let's go. Oh, almost.
Almost. That's really good.
But everybody was correct, I guess.
Mm-hmm. Yes.
Okay. Let me check for, we have a lot of questions. I'm going to, okay, we can, well, it's almost everybody saying about that they can see the questions, that they can hear you. Everybody was telling that the presentation was pretty clear.
Oh, good.
So let's see. Oh, here it's a question from Dr. Martin. I'm sorry, I'm not able to see very well my panel. But the question is, any evidence to support the use of testosterone in the treatment of ER and PR positive DCIS?
That's a really good question. I think I don't know. It's not an invasive cancer. Ductal carcinoma in situ is not an invasive cancer, but testosterone can prevent invasive cancers, and that's what the goal of treating DCIS is about, is the prevention of an invasive cancer. Interestingly, in our prospective study, which we're going to have 10-year results on this spring, we see a marked reduction in the incidence of invasive breast cancers, and we see a much less incidence reduction in DCIS. But again, DCIS is a non-invasive. It's not an invasive breast cancer. So I think there is a role in prevention of disease um, for invasive breast cancer.
Okay, I hope that was clear. It was from Dr. Martin Galli. Sorry, I didn't say the surname. So there's also another question from Elke Reising. It says, any reference for studies that show clear effects, for example, in relation to placebo in DBL blinded trials, of testosterone and aromatase on the numerous positive reported associations? Is the question clear for you,
What was the
Rebecca?
last line of the question?
Yeah, I can very
The
quickly
last
repeat
line
it.
of the
Any
question.
of testosterone and aromatase on the numerous positive reported associations?
No, there are not double-blind that I'm aware of looking at that with testosterone and aromatase inhibitor. The Mayo Clinic did do a study, the Alliance Cancer Trial, which was a double-blind study looking at testosterone with an aromatase inhibitor versus placebo on the side effects of aromatase inhibitor therapy. So that's the only double-blind study I'm aware of. But remember, I'm in clinical practice and treat patients as my number one priority. So yeah, the only one I'm aware of in breast cancer in particular is the Mayo Clinic trial, the Alliance trial.
Okay, Katharina Jansen is asking if you can comment on the scientific evidence of all this.
Yeah, all these, I have references for every single slide, and I'm happy to share those references if anyone wants to email me directly. Every single slide in that presentation, I have references.
Okay, we have some other questions if you have still time, Rebecca.
Sure.
Professor Glaser, yeah. So why is still a problem to get testosterone implants from the US? This is from Joseph Onwude.
Why is it now a problem? What you mean? We're having difficulty getting them, not necessarily in the U.S., but because I think part of the problem in getting implants in the U.S. are those endocrine society guidelines that recommend against treating women. But in Europe, I know that Organon was a major source of the testosterone implants for both men and women. They got bought, and then the company that bought them quit making the implants. There is an implant that's imported to Europe from the United States, and I forget the name of it. It's not Testapel. There's another one now also imported into Europe, but I think the marketing on that's very minimal. But there is an implant available, and if anyone wants to know, I can find out what the name of that implant is and how to get it. Frank Bardani, who originally did the Testapel implant, is the one that's now producing implants for Europe.
Okay. Elke Raising is also asking if you have any comments on intravaginal DHEA for women to treat genitourinary syndrome of menopause.
Oh, I think it's a great idea. I used to treat vaginal dryness and atrophy in breast cancer survivors with a combination of testosterone and estriol, and that worked great also. So I think we got to start looking more at vaginal delivery and the safety of both testosterone, DHEA, and estriol in breast cancer survivors. So I think that's certainly one method of treating vaginal symptoms in cancer patients.
Okay. Amanda Neo is asking what is the best way to assess testosterone and other hormone levels, and are there thresholds above which testosterone treatment should not be prescribed?
Okay, that's a great question. I use mainly serum levels in my practice because we do collect data, and there's much more data on serum levels than salivary hormone levels. I don't use urine testing at all in my practice. It's just something I don't do. And there's no threshold necessarily that I would not go above, particularly in male patients, like that patient with Alzheimer's disease. Again, we maintain his levels over 1500, or he can't remember anything, he can't function. We don't see side effects. Remember, testosterone can fill the androgen receptor. It can't make too much testosterone, it can't overdo it. The problem with high levels of testosterone, though, are that they aromatize to estradiol. And that's when you see the side effects of testosterone therapy. That's when you see the fluid retention, the bloating. That's when you can see an increased risk of thrombosis. And our male patients who 25% at month 1 have a level over 1500 and 65% are over 1100, we've seen no thrombosis in that group of male patients, but we monitor estrogen levels. So I'm not as concerned about the actual value in serum of testosterone. Remember, there are no androgen receptors in serum. It's a transport mechanism to get testosterone to that end organ, to get it to the cellular level. Now, in women, of course, it is cosmetic side effects, the facial hair. That is dependent on the testosterone level, and some women decrease their dose based on the cosmetic side effects.
Okay, so I got that was pretty clear. Michael Bolognese asks, when should T levels be measured in the average male and female? How long should T therapy be continued?
Oh, how long? Okay, I measure testosterone levels in patients that come to me with symptoms of androgen deficiency. And I think, and particularly in women, I think you can continue testosterone the entire lifespan. Many of my patients, particularly upper 70s, 80-year-olds, benefit greatly from testosterone therapy. In that age group, you're dealing with a lot of pain and memory issues, and those are two of the most significant benefits with testosterone therapy. Testosterone does not increase the risk of breast cancer, so that's not an issue as far as stopping or after 5 years. I get asked that question a lot in my practice. So I think people should remain healthy until they die.
Okay, sorry, my microphone was muted. Yeah, I was thanking for the answer. It was pretty clear too. So Monica Flores Ramos is asking about increased levels of testosterone. Could it cause adverse effects, and which ones?
I guess in men, I don't see adverse effects from increased testosterone levels. In women, you do see the cosmetic side effects, and one of them is the increase in facial and body hair. So that is a cosmetic side effect of testosterone that we're well aware of. What we don't see, at least with the testosterone pellet implants, is any change in the voice. So we see no changes in the voice, and we looked at that in a prospective study. So that's one of the myths associated with testosterone.
Okay,
Again,
so
I think most of the side effects from testosterone therapy are actually due to aromatization. And you don't even have to measure high levels in the serum. You've got to look at symptoms because that aromatization takes place at the cellular level. Particularly with the higher doses we give aging men who already have increased aromatase activity, who already may be obese or on multiple medications.
okay. So we are now finally going with the last two questions. One of those is on the same topic as before from Joseph Onwude. Do you know where else we can get these implants from, if not in the US? It's continuing with his previous
I think probably one of the, I don't know if you have compounding pharmacies in Europe, but testosterone implants are very simple to what we call compound. And I don't know if that's an option in Europe, that you can have the pharmacist actually make the testosterone implants. And they're sterilized with autoclave. You mix the testosterone powder with a little bit of stearic acid. You press them, put them in a vacuum sealed tube, and autoclave them. So I can try to find out more information about the implants that are exported from the US to Europe. Or maybe somebody could start a pharmaceutical company and produce them.
Okay, and we go to the last one. It's from Katharina Jansen. What dose of testosterone do you advise in Alzheimer's disease in men?
Oh, in men? Okay, it depends on the symptoms. You have to give enough testosterone to take care of the symptoms. And that gentleman, who is not a large person, is on 2,600 milligrams of testosterone every 12 weeks. He does get that in combination with an aromatase inhibitor, anastrozole, in his pellets. And he started off, when I first saw him, at 16 to 17 or 1,800 milligrams, but he would come back symptomatic for 2 or 3 or 4 weeks. So now his current dose is 2,600. If I have to take him up to 3,000 milligrams, I will, because he's functioning and living an absolutely normal life. He drives, he farms his property, he enjoys his grandchildren. So I have no problem taking that dose up to treat the symptoms. But again, watch the amount of estrogen that's made.
Okay, so I guess it's all the questions are there. So that is pretty much it. So thank you so much, because this concludes the presentation and the webinar. So thank you so much for your wonderful presentation, Professor Rebecca Glaser. And thank you very much also to all the attendees for being here today. Let me just make a very quick reminder to you all. You will be receiving a brief survey. It's going to pop up once you end the webinar. And for us, it's very, very helpful if you can answer it. So we would really, really appreciate the response. Thank you very much, everyone, and yeah, have a great rest of the day. Okay, so bye-bye.
Thank you.
Thank you, Professor Glaser.